Disclaimer: this podcast is for education and commentary only and is not medical or legal advice. Listening to this content does not create a physician-patient or attorney-client relationship. When I discuss lawsuits or court decisions, I'm relying on publicly available records, and I will distinguish allegations from findings. My analysis reflects my opinions about risk, systems, and documentation, not personal judgments about any individual. To protect privacy, I may omit or change identifying details where appropriate. If you need medical or legal advice for your situation, consult a qualified professional. If this is a medical emergency, call 911 or your local emergency number. Welcome to the Charted Defense. I'm glad you're here. Today's episode is about a pattern that can be easy to miss in real time and devastating when it is missed. At first, this case looks like a brain mass with hemorrhage within the mass, likely a newly diagnosed brain malignancy. But things are not always as they seem. A patient arrives with confusion and progressive decline. The initial workup is familiar territory: labs, chest imaging, urine studies, and a head CT. The white blood cell count is elevated. Imaging of the chest is normal, and the urine sample appears normal as well. No source of infection is identified, but sepsis remains the leading diagnosis on the differential. A head CT is ordered for the mental status decline and suggests possible hemorrhage into an underlying mass. That possibility is communicated to the patient's family, and it comes as a shock, but this would explain the symptoms. That framing drives urgent neurosurgical intervention. Intraoperatively, the tissue does not behave like a classic tumor. Pathology later reports no malignant cells, but identifies numerous gram-negative rods. That is a major pivot point. Now we have to ask, was there an intracranial infectious process predating surgery? Is this contamination procedure-related or true disease? Or is the brain finding downstream from a systemic process yet to be discovered? Within about 48 hours, blood cultures drawn in the emergency room grow gram-negative rods, later speciated as E. coli *. Broad gram-negative antibiotic coverage is started. Infectious disease is consulted, and further source investigation begins. At this stage, the key clinical question is no longer only, what is this intracranial lesion? It becomes, what ongoing source is feeding this bacteremia, and has an endovascular infection already developed? Echocardiography demonstrates a valvular vegetation. That finding changes the map. Infective endocarditis now enters the differential in a meaningful way, and with it the possibility of septic embolic spread. In this type of trajectory, one coherent pathway is 1. Bloodstream infection, 2. Valvular seeding, 3. Embolic dissemination, 4. Arterial wall injury, 5. Then catastrophic bleeding when a weakened vessel fails. Important precision point. In cases like this, some elements are established findings and some are reasoned inferences. Established findings in this narrative: bacteremia, gram-negative organism, intracranial hemorrhage, valvular vegetation. Reasoned clinical inference: an infection-related aneurysmal process contributed to rupture risk. That distinction matters for both medical reasoning and medico-legal accuracy.
This is an interesting case to me. It seemed like a straightforward brain mass, which was likely cancer based on the imaging. If this were a cancerous tumor, blood vessels would grow and proliferate as the cancer advanced to continue providing adequate nutrients to the cancer for continued growth. With this increased vasculature comes the risk of bleeding. so it seemed reasonable that this patient's scenario was just a complicated new diagnosis of cancer. Most of us wouldn't think, at least initially, to consider a septic emboli to the brain mimicking a hemorrhagic mass.
Several themes are consistent across the cited literature. E. coli mycotic aneurysm is uncommon, but documented. Persistent or recurrent bacteremia, especially when fever and inflammatory markers fail to settle, should trigger a search for occult endovascular infection. In established infected aneurysm disease, antibiotics are essential, but often insufficient by themselves. Source control strategies are frequently decisive. This is a trajectory problem, not just an antibiotic selection problem. If cultures remain positive or the patient fails to improve as expected, the differential has to widen early. Waiting for the picture to become obvious can mean waiting until instability, expansion, or rupture.
This is not something that is common. We usually see gram-negative bacteremia in the setting of a urinary or gastrointestinal source that goes untreated and progresses to a bloodstream infection. It is not something we think of as a cause of endocarditis or an intracranial infection these days. It's just a reminder that medicine doesn't always follow the expected course. Usually, gram-negative bacteremia clears quickly with antibiotics without any long-term complications. This is in contrast to Staphylococcus aureus, which is prone to causing complications when it gets into the bloodstream.
In this case, ARC, initial imaging suggested hemorrhage into a mass. That was a reasonable initial read. But infectious and vascular processes can mimic neoplasm, particularly when blood, edema, and inflammatory tissue overlap. For intracranial infection-related aneurysmal syndromes, presentation can include altered mental status, focal neurologic deficits, severe headache, neuro-ophthalmic findings such as diplopia, ptosis, ophthalmoplegia, or vision change, or abrupt hemorrhage. If suspicion exists, neurovascular imaging pathways should be engaged urgently, and concern should remain high even when early non-invasive studies are not definitive. Why urgency? These lesions can evolve quickly. Delay increases the chance that first definitive recognition comes at rupture.
My goal with this show is to look at cases first through the medical lens and then through the legal lens. Cases like this can end in disaster, and physicians can find themselves defending both their care and their documentation in a malpractice claim. Now let's look at this from the legal side.
In malpractice litigation involving delayed recognition of mycotic aneurysm or other occult endovascular infection, plaintiffs often allege a pattern. Persistent bacteremia or recurrent fever, delayed expansion of the differential, delayed imaging escalation, delayed consultant engagement, and thin documentation of risk communication. But allegations are not adjudicated facts. For this show, and for physician learning, we stay disciplined. What was alleged? What was actually found or held? And what remains uncertain from the available record? For practicing clinicians, the larger lesson is less about memorizing case names and more about producing a chart that demonstrates active trajectory recognition. A defensible chart usually shows patient not improving as expected, differential broadened in writing, explicit rationale for escalation, timing of imaging and consultant calls, and communication of uncertainty and risk with the patient/family.
In a future episode, I will talk about our documentation and why it is so important that we are actively thinking about what we are putting in our notes. Our documents should not be EMR, generated information mixed with data without context and without our clinical reasoning. We have to make sure our clinical reasoning comes through in our documentation. That may make the difference when our care is called into question.
Let's close the loop with the process clearly. 1. What it is. A mycotic aneurysm is an infection-associated aneurysm caused by microbial damage to the arterial wall. Despite the term mycotic, these are commonly bacterial. 2. How it happens. 3 common pathways. 1. Hematogenous seeding during bacteremia into a vulnerable arterial wall. 2. Septic embolization, often in endocarditis, with infected material lodging distally and injuring the vessel wall. 3. Contiguous spread from adjacent infection into nearby vascular structures. From there, inflammatory destruction weakens the vessel. This may result in aneurysmal dilation or pseudoaneurysm, with potential for expansion, thrombosis, embolization, or rupture. 3. What to watch for. Not one symptom in isolation, watch the clinical trajectory. Bacteremia that does not clear, persistent or recurrent fever despite apparently appropriate antibiotics. Inflammatory markers that fail to trend as expected. New focal pain, new neurologic or visual symptoms, mismatch between expected recovery and actual course. 4. Rare but catastrophic if the source is not identified. This syndrome is uncommon, but uncommon is not the same as low risk. It is a low-frequency, high-consequence event. If source control is delayed or missed, outcomes can include hemorrhage, shock, severe neurologic injury, and death. It also creates intense retrospective scrutiny of timing, decisions, and documentation. You do not need perfect certainty about where the bacteremia started to act decisively when the trajectory signals danger.
Some physicians talk about defensive documentation. Physicians that have been sued before tend to use this language. Defensive documentation is charting that's driven primarily by liability anxiety or anticipated peer review/audit scrutiny, rather than by what best supports patient care, communication, and medical necessity. It often shows up as, if it isn't written, it didn't happen, taken to an extreme, adding volume, qualifiers, and checkboxes to create legal cover, even when it adds little clinical value. It actually is more likely to do something we don't expect. Long templated notes create more opportunities for contradictions, which are a plaintiff attorney's best friend. If your note says you did a full neuro exam but later you document focal deficits, the earlier normal looks careless or false. Copy forward can memorialize yesterday's exam as today's. That's devastating in deposition. That can discredit anything else you have to say to a jury. That can end the case before it even gets started. It owes the seed of dishonesty. Did the physician actually examine the patient at all? Plaintiffs' attorneys can have a field day with that, a rule to remember. The more you document that isn't true/relevant, the more you create impeachment material. The more commentary you put in a note thinking it will protect you, the more likely you are to say something that will harm you. Defensive documentation does something else. It buries the clinical narrative. Clinically important signals such as why you're worried, what you ruled out, what you're watching, when to escalate get lost. That harms your handoffs, cross-coverage decisions, consultant efficiency, nursing alignment with care plan. And if an adverse event happens, the record looks like you didn't have a coherent assessment, even if you did. It is okay to document what we think or what we don't know. It is okay to say, the patient is not improving despite my treatment. It is okay to say, we need to take a step back and reassess the case and our diagnosis. That shows that we are engaging our brains. We are not just following some clinical algorithm, but we are continuously surveilling and monitoring our patients during the treatment plan we implement. We are identifying when a patient is not doing as we would expect and taking a step back and reassessing our differential diagnosis. This information, when documented correctly, can protect us as we take care of complex patients with unusual presentations, such as this one.
The next time you have a patient with a bloodstream infection that is not improving as you would expect, consider documenting and doing the following. First, name the risk explicitly. This patient has a persistent or recurrent bacteremia. Consider causes not previously thought of, such as endovascular infection, or focus of infection elsewhere in the body. Next, trend objective data daily, such as fever curve, white blood cell count, inflammatory markers, and repeat culture status. Remember to escalate imaging threshold early. If trajectory stalls, pursue advanced imaging such as CTA chest, abdomen, and/or pelvis to look for the source. In a patient with neurologic or visual signs, activate an urgent neurovascular imaging pathway. Next, broaden the differential in writing. Include endocarditis complications and infected aneurysm or mycotic aneurysm when clinically appropriate, such as this case. But broaden your differential based on the case at hand, as each case is unique. Consult in parallel, not sequence. ID plus vascular and neurovascular teams when intracranial concern is present. Coordinate antibiotics with source control planning. Both tracks matter. Document decision logic and timing. What changed, when escalation occurred, and why? Communicate clearly with patients/families. This is important. When patients and families are able to see the complexity of our role and their illness, as well as see how hard we are working to get to the diagnosis and start appropriate treatment, they are more likely to trust us and understand that we share their concerns and we are working to get to the bottom. In the case of a mycotic aneurysm, we must be explicit with the risks that the patient faces and make sure they are aware of potential catastrophic outcomes. Plan surveillance before transition of care. Document interval reassessment, return precautions, and relapse monitoring. If teams do these reliably, they reduce avoidable harm and improve medico-legal defensibility. This is why the charted defense exists. The goal is better recognition of dangerous trajectories, while there is still time to change the outcome. If this episode was useful, share it with your friends and colleagues. In the next episode, we will discuss another rare disease process that we should all keep in the back of our minds on the inpatient wards.
I am a hospitalist physician with 15 years of experience in inpatient medicine. I have a passion for risk management, patient safety, and evaluating system vulnerabilities. Join me as we expand this podcast and open discussions about the complexities of modern medicine, take deep dives into what it feels like to go through a malpractice case, and discuss ways we can learn from bad outcomes so we don't repeat them. In this case, the patient was fortunate and survived, though, with some neurologic deficits. There were questions about how the organism was identified in a central nervous system pathology report. Initially, it was thought to be a surgical complication, with contamination occurring during the procedure. Fortunately for the surgeon and the medical team as a whole, the cultures obtained before surgery showed that this infection was ongoing and evolving prior to the patient's presentation to the emergency room. Without those cultures, it's possible that no further workup for infection would have been performed. The patient might even have been discharged home, thinking the issue had been resolved by surgery, only to return in much worse condition, or worse. Imagine this scenario. If this patient had been discharged after believing surgery successfully removed a tumor, what would have happened? We know the pathology report would become available showing no malignancy, which is good. But a bacterial infection within the central nervous system is in itself a life-threatening event. This patient would have suffered much worse if the initial sepsis workup had not been performed. The sepsis workup included blood cultures, which started growing gram-negative rods around 48 hours of incubation, which helped the medical team in reorienting themselves to a bigger problem. It is never normal to have bacteria in our bloodstream. If the patient presented back to the hospital with new or worsening symptoms, or even worse, died, this would look like a classic pattern we see in medical liability. An abnormal lab value not relayed to the patient, and possibly a missed opportunity to intervene. How could we anticipate this type of event? How would we handle this scenario if it were us, and we were faced with a malpractice claim? In future episodes, we will discuss how this could play out in court if a scenario like this were litigated, and how difficult it can be to defend your care, even when most other physicians placed in the same scenario would do the exact same thing. Thank you for joining us.
This content is educational, not medical or legal advice, and it doesn't create a professional relationship. Sources are listed when available. For personal guidance, consult your own clinician or attorney. Thank you for joining our podcast.